Welcome to another episode from the Veterinary Medicine Digest. Today, we are diving deep into one of the most challenging and often heartbreaking gastrointestinal syndromes in veterinary medicine, protein-losing enteropathy, or what we often refer to as the clinical condition that accompanies intestinal lymphangiectasia. This is a complex disease where the body loses vital proteins and other nutrients through the intestinal tract due to leaky lymphatic vessels. Our goal today is to unravel the pathophysiology, explore the cutting edge of diagnosis, and discuss the evolving strategies for managing this critical condition in our canine companions. Intestinal lymphangiectasia, often shortened by practitioners to IL, is not just a straightforward intestinal issue. It is a disorder of the gastrointestinal tract characterized by the pathological dilation and rupture of lymphatic vessels within the small intestine. When these vessels, called lacteals, are pathologically dilated, they can rupture, leading to lymph leakage into the intestinal wall, the submucosa and lamina propria, and eventually into the intestinal lumen. This leakage results in the core problem known as protein-losing enteropathy, or PLE, because the lymph fluid carries vital components such as plasma proteins, particularly albumin, along with immunoglobulins, lipids, and lymphocytes, which are all lost into the gut lumen. In dogs, protein-losing enteropathy is a life-threatening syndrome associated with numerous diseases, but intestinal lymphangiectasia, or IL, is a frequent and highly significant cause. Reviewing veterinary literature across several decades, it is clear that intestinal lymphangiectasia is diagnosed in a significant percentage of dogs presenting with protein-losing enteropathy, around 46 to 58% of cases examined. This loss of vital components leads to a cascade of systemic issues, commonly presenting as hypoalbuminemia, hypoglobulinemia, hypocholesterolemia, and lymphopenia. It is worth noting that while protein-losing enteropathy mechanisms are identical in dogs and people, the underlying causes often differ. In humans, protein-losing enteropathy is typically associated with primary intestinal lymphangiectasia, often referred to as Waldmann's disease. In contrast, in dogs, protein-losing enteropathy is frequently a feature of inflammatory bowel disease, which is known in veterinary circles as chronic enteropathy, and less often primary intestinal lymphangiectasia, though it is often a challenge to determine which process is the primary defect. In fact, intestinal lymphangiectasia and chronic inflammatory enteropathies occur together quite commonly, with one study noting that 76% of dogs with chronic inflammatory enteropathy and low serum albumin concentrations also had concurrent intestinal lymphangiectasia. The severity of the disease in dogs cannot be understated. Published reports show that over half, specifically 54.2%, of dogs with protein-losing enteropathy die from their disease or from severe complications like pulmonary thromboembolism. This fatality rate is significantly higher than that reported for general inflammatory bowel disease, implying that the underlying mechanisms causing the protein-losing enteropathy syndrome are more severe than just the continuum of chronic enteropathy. This high mortality drives the intense focus on optimizing management strategies. To truly grasp intestinal lymphangiectasia, we need to take a step back and appreciate the complexity of the lymphatic system itself. The lymphatics form an extensive, unidirectional drainage network parallel to the venous system, crucial for fluid homeostasis, immune surveillance, and fat transport. Within the intestine, the microanatomy of the lymphatics is layered. The smallest vessels are the central villus lymphatics, known as lacteals. These lacteals are found only in the intestinal villi and, in a healthy state, typically occupy no more than 25% of the villus width. The endothelial cells that form the walls of the capillaries are loosely joined, forming flap-like valves that act like swinging doors, allowing interstitial fluid, along with proteins that are too large to enter blood capillaries, to enter the lymphatic system in a strictly one-way manner. Lacteals connect to the submucosal lymphatic network. These networks drain into larger collecting vessels that contain intraluminal valves and circumferential smooth muscle, organized into subunits called lymphangions. These lymphangions facilitate spontaneous contractions that actively propel lymph away from the intestine toward lymph nodes and eventually back into systemic circulation. Crucially, one of the lymphatic system's primary roles is dietary fat absorption. Long-chain fatty acids, which make up most ingested fat, are absorbed by enterocytes and repackaged into chylomicrons, which then enter the lymph via the lacteal. This entire process puts significant pressure and flow demands on the delicate intestinal lymphatic vessels. When intestinal lymphangiectasia occurs, whether primary, congenital, or secondary, due to inflammation or obstruction, the lymphatic vessels dilate and become damaged. This dilation and rupture cause protein-rich lymph to leak continuously into the bowel. Furthermore, The lymph fluid itself is considered a local tissue irritant, potentially causing inflammation and granuloma formation, which presents a challenge in differentiating primary versus secondary disease histologically. When intestinal lymphangiectasia is present, effective lymphatic pumping and transport is altered due to the inflammation. In addition to protein loss, intestinal lymphangiectasia results in immunological deficits. Severe protein-losing enteropathy in people has led to disease-associated loss of immune function, including lymphopenia and severe CD4-positive T-cell depletion. Although similar studies detailing the immune consequences in dogs are limited, depletion of these key components is similarly expected. Immune suppression is sometimes pursued in canine intestinal lymphangiectasia cases, but this may be counterintuitive or even harmful if dogs experience the same severe CD4-positive T-cell depletion seen in people. The clinical presentation of intestinal lymphangiectasia in dogs is highly variable, but often severe, reflecting the comprehensive systemic loss of proteins and nutrients. Commonly reported historical features include chronic diarrhea, weight loss, vomiting, and decreased appetite. Diarrhea is noted in nearly all cases, reported in 94% of one study's patients. Signs directly associated with the resultant hypoalbuminemia are common and often life-threatening, such as ascites, abdominal fluid accumulation, pleural effusion, fluid around the lungs causing respiratory difficulty, and peripheral edema, swelling, particularly of the limbs. In one study, 28% of dogs presented with clinical signs associated with cavity effusions. On the blood work side, the hallmark is severe hypoalbuminemia, frequently accompanied by hypoglobulinemia, hypocholesterolemia, and lymphopenia. In a large review of protein-losing enteropathy cases, the cumulative median serum albumin level was around 1.49 grams per deciliter. Also common is hypocobalaminnemia, low vitamin B12, and decreased serum concentrations of vitamin D are often seen and are associated with a negative outcome. Because vitamin D and magnesium concentrations can be low in cases of chronic enteropathy and protein-losing enteropathy, these are nutrients of concern. Low blood magnesium may be seen in some dogs with protein-losing enteropathy, sometimes requiring supplementation. A serious, often silent, complication is thromboembolism. Thromboembolism, or blood clot formation, occurs in some protein-losing enteropathy cases, manifesting as sudden death. The mechanism is not fully defined but is hypothesized to involve systemic inflammation, altered vitamin K absorption, and the loss of antithrombin 3, a natural anticoagulant. In published reports, thromboembolism occurred in about 6% of protein-losing enteropathy cases. Certain breeds exhibit a predisposition, suggesting a possible genetic susceptibility to intestinal lymphangiectasia. These breeds include the soft-coated Wheaten Terrier, the Chinese Shar-Pei, the Norwegian Lundhund, the Maltese, the Rottweiler, and the Yorkshire Terrier. The Yorkshire Terrier, in particular, is overrepresented in reports of protein-losing enteropathy in both the United States and Europe. In some cases, intestinal lymphangiectasia presents as a highly localized form known as focal intestinal lipogranulomatous lymphangitis. This form is characterized by a granulomatous inflammation of the lymphatic vessels, often involving the intestinal wall and mesentery, and leading to the formation of lipogranulomas. Clinically, these dogs present with typical chronic gastrointestinal signs, but histologically, there is transmural granulomatous inflammation, often involving the muscularis and serosal layers of the intestine. One study of this focal form reported that 8 out of 10 cases occurred in French bulldogs. A definitive diagnosis of intestinal lymphangiectasia is made through histological assessment of intestinal biopsies. Tissue samples are obtained either surgically or, more commonly and preferably, via endoscopy, particularly given the risk associated with surgery in hypoalbuminemic patients. The core finding is villus lacteal dilation, which is graded based on how much of the villus width the central lacteal occupies. Endoscopy offers direct visualization of the intestinal mucosa. The appearance of pinpoint to coalescing, white spots, on the duodenal mucosa is often associated with intestinal lymphangiectasia, thought to represent the grossly dilated lacteals. Endoscopy may also reveal whitish contents suggesting lacteal dilation and duodenitis. However, this finding is only moderately sensitive and not specific, and not all dogs with histologically confirmed intestinal lymphangiectasia will display these white spots. In fact, some human studies categorize the disease by white villi type versus non-white villi type, suggesting the classic visual signs are not universally present. Furthermore, because intestinal lymphangiectasia can be segmental or affect deeper layers like the submucosa, A superficial endoscopic biopsy might miss the extent of the disease or fail to diagnose it altogether. Ultrasound is a crucial, non-invasive tool. Characteristic ultrasonographic features suggesting intestinal lymphangiectasia include hyperechoic mucosal striations within the small intestine. These striations are reported to be associated with lacteal dilation. In one recent case, hyperechogenic echoes coalesced in the mucosa, suggesting greater lymphatic dilation and inflammation. Ultrasound can also reveal other associated abnormalities, such as intestinal wall thickening, often focal or segmental, hyperechogenicity of the intestinal tissue, abdominal effusion, and lymphadenomegaly. One study noted that oral corn oil administration might help improve the conspicuity of these ultrasonographic lesions by engorging the lacteals with lipid. For the highly localized form of the disease, focal intestinal lipogranulomatous lymphangitis, ultrasound findings include focal intestinal wall thickening, predominantly involving the muscular layer and to a lesser extent the submucosal layer. There may be hyperechoic mural nodular tissue, likely corresponding to lipogranulomas seen on histology, and multiple round or tubular anechoic structures within the submucosa, representing distended lymphatic vessels. A newer, non-invasive technique drawing attention is strain elastography, which assesses tissue rigidity. In a pioneering case report in a border collie with intestinal lymphangiectasia, the semi-quantitative data from strain elastography initially showed increased hardness rates in the intestinal mucosa, suggesting greater rigidity. Following successful treatment, these stiffness parameters were reduced, suggesting that elastography holds potential as a valuable tool for monitoring disease activity and prognosis, similar to its application in human medicine. In terms of non-invasive biomarkers, fecal alpha-1 protease inhibitor concentration can be measured. This is a protease inhibitor that is lost into the bowel during protein-losing enteropathy. Elevated levels support the diagnosis and are reported to reflect the severity of lacteal dilation. Decreasing serum concentrations of albumin, cholesterol, and 25-hydroxyvitamin D also increase suspicion for intestinal lymphangiectasia concurrent with inflammatory enteropathy. The management of intestinal lymphangiectasia in dogs is multifaceted, but the cornerstone of therapy is dietary modification, an approach emphasized heavily due to the lymphatic system's role in fat absorption. The main dietary strategy for intestinal lymphangiectasia is fat restriction. The hypothesis is that reducing dietary fat limits chylomicron production. Since chylomicrons are absorbed through the lacteals, decreasing their production reduces lymphatic flow and pressure, thereby preventing further lacteal dilation and rupture. While there is no universally agreed upon definition of low-fat, diets containing less than 20% fat on a metabolizable energy basis are generally considered suitably low in fat. For dogs with refractory or severe disease, an ultra-low-fat diet, defined as generally less than 15% fat on a metabolizable energy basis, may be necessary. Achieving this ultra-low-fat profile is often best managed through a home-prepared diet using low-fat ingredients. Consulting a board-certified veterinary nutritionist is essential to ensure these highly restricted diets remain nutritionally complete and balanced, particularly regarding essential fatty acids. The level of fat chosen for a dog depends on their current diet. For instance, if a dog is eating 30% fat, a drop to 15 to 20% might be attempted first. A significant number of dogs with intestinal lymphangiectasia respond well to dietary changes. One study involving dogs with unresponsive or relapsed intestinal lymphangiectasia found that 79% responded satisfactorily to dietary fat restriction. Another retrospective study on Yorkshire Terriers with presumptive protein-losing enteropathy noted that clinical signs resolved completely in 8 dogs using dietary therapy alone. Medium-chain triglycerides, or MCTs, are frequently discussed in this context. In people, MCTs are highly beneficial because they are water-soluble and absorb directly into the portal vein, completely bypassing the intestinal lymphatic system. This allows for nutrient fat provision without causing lacteal engorgement. However, this critical difference must be noted in dogs. MCTs are still absorbed into the lymphatic system in canines and therefore may not directly help reduce lymph flow or pressure. Despite this, MCTs have been shown to modulate intestinal inflammation and may cause less damage than long-chain triglycerides, suggesting a potential anti-inflammatory benefit in canine intestinal lymphangiectasia. Since dietary fat restriction is the main focus, supplementation of other nutrients is key. Dogs with intestinal lymphangiectasia often develop deficiencies in cobalamin, vitamin B12, vitamin D, tryptophan, and magnesium. Supplementation of these is warranted, especially cobalamin, as hypocobalamin is a negative prognostic indicator. If a dog is on a low-fat diet, supplementation of fat-soluble vitamins, specifically A, D, E, and K, is particularly important. In addition to highly tailored diets, enteral nutritional support should be strongly considered. When a patient, particularly breeds like the Yorkshire Terrier who can be fussy eaters, is unwilling to eat the prescribed low-fat diet or is severely debilitated and hypoalbuminemic, placing an esophagostomy tube should be considered a life-saving measure. Assisted enteral feeding has been significantly associated with a positive outcome in dogs with inflammatory protein-losing enteropathy. Tube feeding allows for guaranteed caloric and nutrient intake using blenderized low-fat canned foods, sometimes supplemented with whey or pea protein powder, divided into small, frequent meals. Feeding small, frequent, high-protein, low-fat meals may also help maintain a mildly hyperosmolar intestinal lumen, which theoretically can slow or stop protein loss by manipulating the osmotic gradient. Moving beyond diet, the use of medications in canine intestinal lymphangiectasia involves both standard supportive care and controversial immune-modifying therapies. Standard management often involves glucocorticoids and sometimes other immunosuppressive agents. Prednisolone is the most commonly used immunosuppressive agent. However, the use of immunosuppressives in primary intestinal lymphangiectasia is highly controversial. In humans, these agents are rarely used for intestinal lymphangiectasia because there is no strong evidence for an autoimmune or immune-mediated cause. In dogs, intestinal lymphangiectasia is often secondary to chronic inflammatory enteropathy, which is treated with immune suppression. However, the sources emphasize that the inflammation seen in intestinal lymphangiectasia may simply be a consequence of the leaking, irritating lymph fluid, not a primary immune dysfunction. Furthermore, because protein-losing enteropathy causes the loss of immune components, initiating immunosuppression could be precarious. High doses of steroids can also be detrimental, causing muscle protein catabolism, hyperlipidemia, and promoting thrombosis, all undesirable side effects in a dog with protein-losing enteropathy. One retrospective study found that dogs treated with dietary therapy alone had significantly better outcomes than those treated with immunosuppressive therapy. Therefore, it is suggested that immunosuppressive doses of steroids, defined as greater than 1 mg per kilogram orally every 24 hours, should be avoided in dogs with intestinal lymphangiectasia, unless there is a strong, compelling diagnosis of immune-driven inflammatory enteritis. For thromboprophylaxis, which is highly recommended due to the high risk of blood clots, agents like clopidogrel or low-dose aspirin are often used. The optimal dose and duration are unknown, but prolonged treatment may be necessary even in clinically remitted dogs who can still suffer sudden death from a thromboembolism. A novel therapeutic approach being explored in dogs is the use of octreotide. Octreotide is a long-acting somatostatin analog successfully used in some refractory human cases. It is thought to decrease intestinal fat absorption, inhibit gastrointestinal vasoactive peptides, and potentially stimulate the autonomic nervous system, leading to reduced chyle production and intraluminal pressure. A recent retrospective study examined the use of octreotide in 18 dogs with protein-losing enteropathy, of which 92% had histologically confirmed intestinal lymphangiectasia. These dogs were typically refractory to standard therapies, including therapeutic diets and immunosuppressives. For the 12 dogs in the study where octreotide was the only change to therapy, 50% showed apparent clinical improvement. Improvements noted included better stool consistency, reduction in peritoneal effusion, better appetite, and increased energy. The median dose used in the study was 20 micrograms per kilogram subcutaneously daily, often divided every 12 hours. Octreotide was generally well tolerated, with adverse effects reported in only 17% of dogs, mainly injection site pain or urgent watery diarrhea. The dogs that showed clinical improvement were generally on a lower fat diet, median fat content of 15 grams per 1,000 kilocalories, and received a slightly higher dose, median 30 micrograms per kilogram daily, compared to non-responders. While this study cannot confirm a definitive benefit due to its uncontrolled, retrospective nature, it shows octreotide is well tolerated and warrants further controlled investigation, especially in refractory cases. Other supportive care includes addressing concurrent gastrointestinal issues like nausea or vomiting with antiemetics, managing pain, and potentially using prokinetics if intestinal hypomotility is suspected, as lymph stasis can develop. Addressing fluid accumulation, ascites or edema, with diuretics is generally not useful, as the fluid is related to low plasma oncotic pressure, not fluid overload. Oncotic support measures like hydroxyethyl starch or plasma transfusions can be life-saving in critical patients, but the effects are transient as the administered proteins are quickly lost through the leaky gut. Ultimately, intestinal lymphangiectasia and protein-losing enteropathy are complex, potentially fatal diseases that require highly individualized therapeutic interventions. Future studies are critically needed to refine diagnosis, perhaps making routine use of immunohistochemical labeling of lymphatic endothelial cells to ensure the diagnosis is not missed in superficial biopsies. Research is also needed to better define which patient subpopulations, such as those categorized by clinical activity index scores, are most likely to benefit from specific dietary, immunosuppressive, or novel pharmacological strategies like octreotide. The investigative history of diseases like E. coli-associated granulomatous colitis and boxer dogs reminds us that sometimes, what is presumed to be an immune-mediated condition requiring suppression is actually an infectious process requiring antibiotics. This underscores the importance of a cautious, evidence-based approach to immune suppression in intestinal lymphangiectasia, making dietary management the safest and most important focus until the pathophysiology is completely understood. Thank you for listening. The titles for the reference papers are in the video description. From Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging,